My name is Susanna Oriana, and today, October 29th, I will be presenting my case study presentation on mononucleosis. This is a typical patient presentation for mononucleosis. A 19-year-old male presents with fever, fatigue, joint pain, and a headache. He later reports having painful pharyngitis, which was the reason this patient sought treatment. Upon further examination, the patient has grayish-green thick exudate in his throat and cervical lymph node enlargement. Etiology: most common cause is Epstein-Barr virus, EBV. Although there are many ways to transmit EBV, these are the two common ways to do it. Transmission happens through person-to-person contact because the virus may shed in salivary secretions at high levels for a prolonged period. Sometimes it can last for decades. The last way to transmit is through blood transfusion, although it is very rare. Other viruses that cause symptoms resembling IM are cytomegalovirus, CMV, adenovirus, and HIV. Background: in the United States, the general population is approximately 5 cases per 1,000 persons. However, in a practice with a large young adult population, the incidence can approach 9 to 48 cases per 1,000 persons annually. An example of a practice with a large young adult population are universities where contracting mononucleosis is very prevalent. This disease also has a very low morbidity rate. In rare cases, splenic rupture can occur, estimated to occur in 1 or 2 cases per 1,000. Approximately 70% occur in males, although under 30 years. Some of the risk factors are that it occurs between ages 15 to 24. Typically, those who are in this age range are in high school and in college. Another symptom is contracting Epstein-Barr virus, and the other one is kissing. This one is mainly contracted this way, which is why it is sometimes called the kissing virus. Sharing drinks, toothbrushes, or anything that touches the mouth and saliva. This is another common way of getting mono since it is a direct exposure. An example of this is also trying someone else's food. Another risk factor is also sexual contact, having blood transfusion, and having a compromised immune system because the body isn't able to fight the virus properly. Pathophysiology of the Epstein-Barr virus, since mononucleosis is caused by this virus. After exposure in oral cavity, EBV infects B lymphocytes. Morphologically abnormal or atypical lymphocytes develop, mainly from CD8 plus T cells that respond to the infection. After primary infection, EBV remains within the host, primarily in the B lymphocytes, for life and undergoes intermittent asymptomatic shedding from the oral pharynx. Symptoms: the signs and symptoms of infectious mononucleosis are the result of viral replication and the host immune response to viral antigens. Host immune responses are fever, sore throat, and cervical lymph enlargement. These mechanisms protect the body against disease. The picture shown here also demonstrates the main symptoms of infectious mononucleosis, and some of these are the throat becomes sore and also begins to be red. The lymph nodes are all swollen. The tonsils become red, also swollen, and begin to have white patches. The spleen also becomes enlarged and therefore causes abdominal pain. Symptoms continued. These symptoms occur when mononucleosis is in an advanced stage, but it is not common. Characteristics with progression are generalized lymphadenopathy due to immune response of infection. Enlarged spleen, it begins to filter both normal and abnormal cells. Spleen also begins to hold onto too many platelets, which function to clot your blood. As excess platelets and red blood cells build up within your spleen, it could rupture. Typical manifestations are abdominal pain or falling hematocrit. When splenic rupture occurs, it does so spontaneously. It typically occurs about 14 days after symptoms onset. However, in some cases, it can be a presenting symptom. There are 3 ways to diagnose mononucleosis, and some of these are white blood cell count. This looks for lymphocytosis, which indicates immune response from an infection. Atypical lymphocytes are also present. The other one is heterophile test, also known as monospot test. This is when IgM antibodies appear during the first week of IM symptoms. Results of heterophile tests typically return more quickly, which is why it is a diagnostic test of choice in many clinical settings. The last diagnosis is EBV-specific antibodies. Although the measurement of EBV-specific antibodies is usually unnecessary since most patients are heterophile positive, but it is used when patients test negative for heterophile when experiencing similar IM symptoms. There are 3 treatments for mononucleosis. Some of these are symptomatic treatment. This provides supportive care for the patient. Acetaminophen or non-steroidal anti-inflammatory drugs for treatment of fever, throat discomfort, and malaise. Provision of adequate fluids and nutrition is also important. It is prudent to get adequate rest, although complete bed rest is not necessary. The second treatment is antiviral treatment, a cycloclear nucleoside analog that inhibits permissive EBV infection through inhibition of EBV DNA polymerase. Short-term suppression of oral shedding can be demonstrated, but there is no significant clinical benefit. The last treatment is to refrain from contact sports due to the risk of rupture of enlarged spleen. All athletes should refrain from sport activities during early illness. As recuperation occurs, doctors should keep in mind that spontaneous or traumatic splenic rupture appears more likely within 2 to 21 days after clinical symptoms. Some doctors recommend potential resumption of sports activities no earlier than 21 days after illness onset. Others advise a 4-week time frame regardless of activity level. If splenic rupture occurs, serious complications will develop, including death. These are my references.